Hello, everyone, and welcome to our workshop, A Community Approach to Improving Access to Behavioral Health Services. My name is Anna, and I'm going to be your host for this session. We'll have 50 minutes from 10 a.m. to 10:50 a.m. Central Time and a 10-minute break between sessions. Before we start, we have a few housekeeping items to go over. Firstly, this is a safe and supportive space. Secondly, please help us maintain a respectful and inclusive environment. And finally, please use the chat function in the Zoom to interact with other attendees. For questions for the presenter, please use the chat box. Lastly, we have a couple of forms to complete. If you have registered for a continuing education credit or CEU, please be sure to fill out the sign-in sheet and this CEU form. We'll also post a link for the workshop evaluation in the chat towards the end of our session because we value your feedback and want to make sure we continue improving our offerings. Please join me in welcoming our presenters, Lisa McKenna and Brianna Dominguez. Thank you so much.
Hi, good morning. I'm Lisa McKenna, and we are going to talk about a community approach to improving access to behavioral health. I'm going to discuss how we've improved our emergency department experience due to the volume that we've been seeing over the last 3 years. We've made it's tripling at this point. And I'm also going to be talking about how we have implemented a hospital-based transport team to assist, as well as implementing mental health specialists in 6 schools. And Brianna is going to be discussing.
Good morning. My name is Brianna Dominguez, and I'm another behavioral health manager over at the health plan side of Driscoll Health System. And I'm going to be talking to you today about some of our mental health behavioral integration pilots of mental health clinicians into embedded PCP, primary care physician practices, as well as the startup of Triple P positive parenting program within our health plan. So thank you for having us.
So I apologize, but not seeing the first slide is what's up. I just want to make sure. I think that we would go on to the next slide is the service area that we cover. Or, yeah, slide 3, please. Yeah, so that's a service area where we cover 31 counties and 33,000 square miles. As you can see, it's a pretty vast area that we cover. And it's challenged our workforce, having licensed clinicians due to the volume. Right now, we are seeing a significant number. We're averaging about 92 a month in our emergency rooms, opposed to about 48 per month in 2020. So we're going to discuss the following efforts that we've undertaken. And then to the next slide is just a you can kind of see a little bit of a graph and how we're trending. That's just one example. It's a little bit older. If I would have, should have printed out the one for this month, we actually trended up much higher. Again, we're more than doubling at this point. We can go to the next slide. So again, 2023, we're on track to exceed over 1,000 behavioral and mental health patients. On average, I would say we're seeing about 5 to 6 in our emergency departments on any given day, with suicidal ideations or suicidal attempts, as well as anxiety and depression. We are working on improving the experience through the ED through having appropriate levels. And part of doing that is hiring LPCs and LCSWs to be in the ED to provide immediate assessments. And then recommending to the physicians the appropriate level of care. If an inpatient psychiatric hospitalization is determined, we then work on getting them facilitated and transferred. And this is where we brought in our hospital-based transport team. It is specifically designed to be there to de-escalate along with licensed clinicians with any of our behavioral mental health patients. We have found a significant decrease in our time. Decreased time in our ED. We were averaging anywhere from 12 to 24 hours in our ED. Since we've implemented the licensed clinicians and the hospital-based transport team, our average length of time is 4 to 5 hours. And we haven't in several months admitted anyone to the floor unless they needed medical clearance. So we've made a significant impact, especially with the numbers doubling as they are. On to the next slide. And I'll hand it back over to Brianna to talk a little bit about her programming.
Thanks, Lisa. Yeah, so as I mentioned earlier, I am with the Population Health Management Program. And one of our efforts to really link those gaps that we're seeing in our mental health crisis is done through our population health program. That's on the insurance or the managed care or organization side of Driscoll Health Plan. So as what we've done is we kind of looked at our member panels, tried to help us identify those 4 larger primary care pediatrician settings for our members. Really kind of looked at those with higher admission and readmission rates. And what we did, we went into contracts. We teamed up with them, working to embed behavioral health clinicians within the practice, kind of trying to bridge that gap. We've got kids showing up for maybe their Texas Health Steps, their yearly checkup. Maybe they're in need of referrals to those mental health professionals, but that follow-up just isn't happening. So we really try to target it from a different perspective in looking at those both emergency room and inpatient the admissions and readmission rate. So with that said, we helped these primary care practices find, locate, train, hire a mental health provider. That could be an LCSW, that could be a LPC, just somebody who's able to address the counseling needs for the members within that practice. So we worked on different contract carve-outs, different alternative payment models. The 2 main things we were looking for them to be able to provide was CBT, the cognitive behavioral therapy aspect on an individual basis for the kids, in addition to something in more of a family therapy type setting through a positive parenting program that we are backing here at Driscoll Health System. We've learned a lot in working with the individual practices over the last year and a half. Each practice kind of has different processes in place. They have a different culture themselves. Really trying to work with them on development of workflows. And then we meet on a regular basis to discuss how they're doing. We look at those readmission rates of the kids to see if they're trending down. Really kind of trying to focus on the depression and anxiety diagnosis. One thing I think we've continued to see over the last couple of years is we've got these really long wait times for specialty psychiatrists, psychologists, and a lot of those are being taken up just by kids with a primary ADHD diagnosis. So our intent with that was really to kind of allow those appointments, or set up for more of those appointments to be available for our higher level needs, for those more severe diagnosis, and keeping these PCP offices with a large population of behavioral health diagnosed kids and ADHD, keeping a co-located provider there in that office to where they can handle those needs that aren't quite at the level to require psychiatry intervention and such. We can go ahead and go to the next slide. So again, in recent community needs assessments by both Spawn and Driscoll Health Systems, again, mental health, behavioral health is that #1 community health need. We used to see it in significant numbers of secondary diagnoses. Now it's both secondary and primary. So again, our goal is just kind of to shift that population to be able to be managed in an integrated primary care setting as much as possible. we can go ahead and switch slides again. So on our end, again, we funded the clinician. We did contract carbons for counseling. We are incentivizing completion rates for the Triple P positive parenting program, which I'll talk more about in just a moment. We do a lot of data sharing to look at these trends, again, focusing on the readmission rates, both inpatient and emergency department. We also added a behavioral health consultant on board with us to kind of help us work with the individual practices to work through those barriers. You know, in the first year and a half contract that we did, we were able to get them to, you know, a basic close collaborative model. Ongoing, we're really hoping to see to move more into a true integrative model. One thing we are doing to help these practices identify these members is upon our notification as a health plan of finding out that they've been admitted or discharged to an inpatient hospital or an ED visit, we are notifying the behavioral health provider over at these integrated offices. Again, main goal, trying to reduce the numbers of ADHD members being treated by psychiatrists, trying to free up some of that time. Linking kiddos, you know, to that cognitive behavioral, those evidence-based therapies there in their PCP office, which, you know, is a place that they're most likely already comfortable with. Sometimes we can talk about we often hear the need for the provider, but maybe that doesn't happen. So again, couple things that we've noticed is you really need a PCP, a champion within that practice to back this, to make it successful. You know, we want the providers, the docs, who are the NPs who are seeing the patients in office to be able to say, hey, you know, I've identified a need, maybe it's just for the family, for the parenting program, or maybe it's individual therapy for the kiddo, but for there to be that direct collaboration between providers to ensure that it's a successful referral. So I know I keep saying Triple P, and I'm sorry, I never know which to talk about first, but if we can go ahead and change slides, I'll talk a little bit about this other component that is pretty big within our integrated practices. So Triple P positive parenting program, it is designed to treat behavioral emotional programs. Really, you know, main goal there is to reduce the maltreatment patterns that we continue to see that are happening as a result of behavior. Some of the main catches there, it's evidence-based, it's got a population approach, culturally competent, it's really flexible in its delivery, and it's got a lot of research, many years, decades of research to kind of back its support. And we'll go ahead and switch slides, please. So again, it can be, it's used as a preventative approach. You know, it can be used for those with young children. It can be used for those with school-age children who maybe some of those mild or moderate behavior difficulties are happening in the home. I mean, it also has aims towards those with more severe behaviors and diagnosis. Those may be juvenile justice involved youth. Those on the verge of needing a more restrictive type of placement. So again, it's kind of all encompassing for birth to 17 years old. We can go ahead and switch slides. Thank you. So a little bit about why we chose Triple P. Just you know, the study showing its effectiveness in reducing disruptive behavior. There's studies over 25 years, over 50,000 children, just kind of showing the reduction of those conduct disorder diagnoses. You know, and really, if conduct disorder diagnoses were reduced by just 6.5%, Triple P would pay for itself time and again. So we really, we were excited to implement this for our Driscoll Health Plan members. We were excited for our behavioral health integrated primary practices to offer this to members as well. And we will go ahead and change slides. So that was just a little bit about Triple P, but again, the behavioral health integrated pilot that we've been working on, we we started again by identifying that practice champion, those physicians within these practices, working with them on development of workflows, policies, making sure that they were doing the right screenings in office, making sure that those suicide risk screenings were done for anyone over 12, really helping to, again, give another identifier for this population and try to reach them proactively. We allow for them to have availability for consultation to psychiatrist staffing over the phone. We meet with them, we pay for the triple P, positive parenting training and accreditation. And again, I think I mentioned we are making them aware of any of those behavioral health admissions so that they can reach out on their end as well. So we really kind of tailored the support that we're offering to each of these individual practices based off of their needs, based off the providers in the office, the providers, how comfortable they were around behavioral health in general. And we'll go ahead and switch slides. Again, we are incentivizing the completion of the triple P positive parenting program. And when I say completion, there's pre-surveys, there's post-surveys. We're incentivizing for those completions of cognitive behavioral therapy. I do, again, think I mentioned that we brought a behavioral health consultant on board to really kind of help us with those challenges and struggles that I mentioned. And we've seen a lot of success. We completed our first 18-month period, and we are just finalizing the contracts and alternative payment incentives in place for our next 18-month period. One of our larger practices, we were actually just successful in bringing on a second mental health practitioner that's available there in the office. So one's going to provide triple P positive parenting at a lower level, and one will provide a little bit more intense support of the parenting program. But yeah, we're really excited to see that growth. It's been successful. It has most definitely not been successful at all. It is challenging. But for the ones that has been successful, we're really excited to see where that's going to take us. Next slide. I can see that I get ahead of myself. I say all of this before we get to the slide, so my apologies. But again, I think I did mention that we are supporting these practitioners in becoming certified and accredited for this positive parenting program. And I do know I mentioned the incentives. We can go ahead and change slide. So yes, I just mentioned it again. We're working on those contract finalizations for the next 18 months. Very excited to see the growth. It's been a fun project. It's really been fun to see that linkage. One LPC in one of our provider practices just in a 12-month period had over 1,300 individual counseling claims that were billed. We do allow for those practitioners to bill fee for service for Medicaid, so that is going to them as a practitioner. And then again, those incentives and contract carve-outs are done more at the physician at the practice level. And with that, I'm going to turn it back over to Lisa to talk a little bit more about their CCISD project.
Yes, so I'm going to talk about Corpus Christi Independent School District. We have nearly 50 schools. Of that, we have about 36 elementary schools, and we've been fortunate to have a grant that has been afforded to us by the Coastal Bend Community Foundation. They initiated $800,000 to help us launch a 3-year mental health pilot program. This is designed for us to work with teachers, parents, and children to address the multifaceted challenges that we've been discussing. With this partnership pilot program, we were able to place 6 licensed mental health professionals, which include clinical social workers and licensed professional counselors. They are Driscoll Children's Hospital employees, so we act as our own therapeutic clinic. So I guess for lack of better words, we don't have the red tape as like in a school district where we can provide diagnosis and therapeutic treatment. And kids can receive individual as well as group therapy. And And Triple P has been embedded in our program as well for the families. Anybody that is part of any of our 5 elementary schools and 1 high school, they at no cost will receive Triple P, parenting, individual and or group, and seminar training. Our program the goal is to significantly, we hope to help CCISD because of like I said, they have nearly 60 schools, 36 of them are elementary, and so they have approximately 6 to 7 social workers across those 36 elementary schools, I'm sorry. That means that the social worker or clinician is only able to spend about a half day or maybe a day at one school. They're stretched between 4 to 5 schools. With our program, our clinicians are housed in a specific school. So they are there for that elementary school. They're there for the staff. They're there for the parents and for the students. And so this way we able to provide the individual and group therapy there right on campus. We implemented the program. Well, we got the grant in January of 2022. It was very fast running. I guess we can go to the next slide. I apologize. Okay, so yeah, to talk a little bit more, to go back, we do have the Texas Child Access through telemedicine. Some of you may know it as TChat. And just to let you know that that is in some of our high schools. So making the decision to be based in elementary, middle school, or high school was difficult. We did feel the need to be in everywhere, but the district had chosen for us to be primarily in the elementary and 1 high school because they have the TChat. So that's kind of the explanation behind that. In terms of our training, once we hired in January of 2022, our staff were trained in the Triple P and the Unified Protocol. So they've all been, they had 90 days basically to get all of this training, which wasn't easy, and then to acclimate themselves into a school district that are not, they don't have therapists there. So I will tell you that has been a challenge, but we've been more and more accepted as we've seen the progress we've made with anxiety and depression with our students. We could go to the next slide, please. That just again, got ahead of myself, kind of like Brianna had said with herself, but what talks a little bit more about the TChat, that it allows telemedicine access for the school districts to help identify and assess the behavioral health needs of children and adolescents and provide access to mental health services at the high school level. I want to add with this, before we started our mental health pilot program, we heard there was some difficulty in getting consents for the TChat. So as we identified them coming through our emergency room at Driscoll Hospital, or they were a health plan member, we were able to gain consents that way to increase the numbers of the children and adolescents being able to access that service, because many of them were having trouble accessing or getting consent from the parent and caregiver. Okay, we can go to the next slide. So this is just a kind of what our mental health specialists are. Talks about like a licensed clinical social worker, is a mental health professional who has a master's degree in social work and has obtained a license to practice in their state. The scope of practice for, forgot the L, CSW varies by state, but generally they are trained to diagnose, treat mental health disorders, and provide therapy and counseling services to individuals and families and groups, and to diagnose and treat mental health disorders such as depression and anxiety. I'm primarily going to stick with the depression and anxiety because that's what our unified protocol we've been trained in, and we are able to diagnose and create therapeutic plans. The next slide, please. And this just kind of graphs kind of what an LPC, a licensed professional counselor, and what an LCSW is. I actually put the slide in because I wasn't sure all of our audience, and working in the hospital, I was very surprised. Even many of our physicians, I'm not sure of rules of what an LCSW or an LPC do in terms of diagnosing and treating. I try to explain to them we can pretty much do everything except for prescribe medication. So I kind of put this in here because I wasn't sure of the audience. So We can kind of skip over this, but you can have this for your own reference if anyone needs to understand more of what our role is and what's within our scope. So, and this just talks again about the LPC standing for licensed professional counselors. We're able to assess, diagnose, treatment planning, therapy, crisis intervention, and consultation. The next slide. Okay, so this is what I'm going to talk about, the unified protocol. It's the transdiagnostic treatment of emotional disorders in children and adolescents. The UP, it's actually, so if we could go and talk about bear with me for 1 second because I kind of mixed up my slides a little bit. So I want to tell you what the unified protocol is first. So it's a form of cognitive behavioral therapy for individuals diagnosed with anxiety disorders and depression and related disorders, which we refer to as emotional disorders. The UP is a transdiagnostic treatment. What this means is it can be applied to a range of different disorders and problems. Example, panic attacks, social anxiety, obsessive thoughts, compulsion, depressed mood, and impulsive behaviors. The overarching goal of the UP is to help patients learn new ways of responding to uncomfortable emotions to reduce the symptoms across the patient's range of problems. The UP combines elements such as mindfulness, cognitive therapy, and behavioral therapy. Again, this is what all of our 6 licensed clinicians have been trained in. We also use surveys such as the PHQ-9 and also the Child and Youth Resilience Measure survey, so that we could do a baseline, and then we'll also do a mid and then a post when they're done with their treatment as well to measure. And we can go to the next slide. This is just, I thought this was what one of the students, an elementary student had did, and I just love this. It just shows kind of the work that we're doing. As you can see, you know, this young girl was struggling, and so her and the mental health specialist worked on, you know, some feelings, and she was able to identify, as you see, you know, I am strong, I am kind, I am brave, and all these positive affirmations, which are so important. Just having someone there to listen to these kids has just been just affirming and being there for them. We have had great success with this program thus far. So that's why I wanted to share just a little bit with that. But I also wanted to share a few comments that we were provided. I mean, I want you to know, first of all, I did mention in the beginning that it has been some difficulty for us coming into a school as a therapist, as a clinician, when many of the social workers or counselors, they're not able to act in that role within the school district. But we have been working together and being able to, they're seeing the good that we're doing with the clinical work, and we've built a lot of bonds. They have said that they feel really, supported by us, because not only are we helping the students, but we're also providing time to process with the teachers and staff. Many of the staff are burnt out. I went there one day and I just came across the teacher, and I was just kind of, I go to the 6 schools and just talk with everyone and see how things are going. And this one teacher was just sitting by herself, and she said to me, I asked how she was doing. I told her about our program, and she was like, oh, I had no idea. And then she said, you know that every morning I try to make a decision whether I should go into the school. And she started sharing all of her feelings and thoughts and the challenges going on. So I want you to know that we're not just there for the students, we're there for the staff and the teachers. We're there to help them in finding ways to process their feelings, and we're creating calming corners and developing behavioral plans. So we're there to support all around everyone. And again, we're there, we're in the building, we're present. We have an office there that they can come to. So we're not stretched thin, and we're not running around to different schools. And it's made a huge impact. So I just wanted to also add that with the drawing of the little girl, I just want you to know that this, to reiterate the importance of this pilot program, and that going back to that drawing, I wanted to say about the fourth grader. She started cutting, fourth grade, started cutting herself due to struggles with self-esteem and negative self-thoughts. And I wanted to go back to that flower. And that was last year. So from the time she started working with our mental health clinician in March of 2022, by the end of May, this is what she was able to do, and talk about her feelings. So this is just one example of how we are making an impact in our schools. So with that, I'd open up things for questions. I did share in the beginning, that's about our mental health pilot program. I did discuss a lot of other things that we're doing within the community. I think the biggest thing right now is our pilot program, and also working with our patients that come into our emergency room and spending more time and finding the appropriate level of care and doing a lot of follow-up. And as you can see, there's some pictures of our clinicians that came up. This is just, I mean, it is so fun. And here's our information. Oh, back to the. So these are just some various pictures. One day, I went at 4 of the different schools and took some pictures of some of our clinicians, and just wanted to share that. Now we're open to any questions that you might have. I know I covered a lot about what we have, including our transport team, our emergency room, our being in the communities with the schools, and everything Brianna has talked about. So there may need, if there's any clarification needed, or maybe we could spend this time specifically on questions that you all may have. And were we going to read the questions and chats, or were you going to read them to us?
Either way, if you want to read them, that would be great.
Okay, so do we just,
Yeah.
Actually, I'm happy to read them. So the first question, it's in the Q&A section at the bottom of the screen, but it's by Lisa, and she asks, do all DHP members have access to this program?
Yes. I'm not 100% sure which program specifically, but all DHP members do have access to triple P education. And again, those are done in different levels. We have community programs for group type seminars. We have individual brief, 15 to 30 minute interventions that can be done telephonically or in person. We also have those longer, more intense 1 hour individual counseling sessions that are being billed. But yes, we do have different practitioners in each of our service areas available for that intervention. As far as the behavioral health piloted programs, we definitely can't sway or encourage anybody to move to, say, a PCP practice that has an embedded mental health provider. But if they are an existing patient or do seek services from those physicians, then that embedded in-house practitioner is available for counseling and therapy, as well as triple P to the family. But the triple P program, actually, the intervention itself is designed to be delivered to the caregiver. So that's why we really kind of took that multifaceted approach of, having the individual CBT, that kind of following that unified protocol that Lisa was talking about, available for the Driscoll Health Plan member themselves. And if I did not answer your question directly, which I've done before, please let me know.
And I will say, I know I mentioned that with the 6 piloted schools that we have, the 5 elementary and 1 high school, if they are not a Driscoll Health Plan member, the triple P program is at no cost. And so I do see another question. Now I'm going to skip over the second one, go to the third, because it kind of goes with cost, and then I'll go back. It says, our LPC service is billable with Medicaid and other health insurances. So with this pilot program, we're just getting trained up and getting in there. We are now in the process of it being billable. We don't expect everyone to be billable. If we capture 20%, our goal is to make this program sustainable. So if we are able to, we are capturing insurance information and we're just starting that process. But for the first 6 months, we have not billed, and we still have yet to bill yet. That's something in the future. It's a 3-year program. We hope to get there. It may be around year 1. But our goal right now is just to get in there and get the treatment. But eventually we would need to start billing. And again, not at 100%. If we get 20 to 30%, that would be great. We're just working on making this program sustainable. And then to go back up to, and do we provide substance and use treatment for youth? And if not, do we refer these services? And are we seeing a need for substance use treatment? Absolutely. So coming from a hospital perspective, absolutely. We are seeing definitely co-diagnosis. We're seeing a lot of drug use with depression and anxiety as well in the schools. If we are not able to, we do refer out though, just so you know that there's only so much we can do as a clinicians, and whether you're in private practice or inpatient and within our scope. So depending, some of our clinicians have specialties, some of them are licensed chemical dependency counselors as well. So if we do have somebody available that is able to fit that level of care or that specific need, then they will go ahead and work with the child or youth. If not, we absolutely do refer out. So another question is, and again, like what Brianna said, if not answering any of these questions directly, please ask us again. It's not easy doing this virtually. It's hard to read people who can't see your faces. So I find it difficult virtually. I'd much rather be there in person. So please reiterate or ask us for clarification. So are students and or parents limited to a specific number of sessions? If yes, how do you navigate new issues that pop up during the course of treatment, which may warrant an extension? That is an excellent question, because it is supposed to be, short-term, brief, solution-focused therapy. However, things may come up, but they may be, maybe parenting. It may be, maybe they need to be referred to Triple P. Maybe we need to have more individual. We have not put a limit. We would like to say, 5 to 6, but they could be up to 21 sessions. But we want to see children learning these coping skills, and that's part of our measurement. And they may need a higher level of care. It may not be at that point, they may need more care than what we can provide. But the goal is usually, about 5 to 6, if not up to 21 sessions typically. That's been kind of what we have learned by being trained through UP. And so far we're seeing that, and we're seeing kids, that are saying after so many sessions, okay, I'm good. And we've also had an increase in the beginning. We've got a lot of anxiety or attachment disorder, separation anxiety with the elementary kids, where we've gotten a lot of consents. In the beginning, we see, maybe they need to be seen 3 or 4 times. And then as we follow up, the parents are like, no, they're doing great. But it's great to know that you're there if something does arise. So that's an excellent question. So how did you get support and buy-in for the work you are doing? Oh gosh, persistency, passion, and we have great leadership within our health system that have advocated for a long time and the need. And being in Texas, our numbers are staggering in mental health. And we've written grants, we've pleaded, we've had, and also I'm going to be very transparent, as we've had people in the community that are part of big organizations who have been affected by mental illness themselves and or their child, and have realized how important mental health is. And by that happening, has been able to afford the opportunity for other people to receive some of these services. How would you suggest that individual practitioners, LPCs in the community, seek to partner with the local district, either to provide services on campus or be an external referral source? I hear from colleagues, LPCs, that seeking to establish a partnership with schools can be hit and miss. Absolutely. I would, my email is on here, and if you want to reach out to me offline, I'm happy to share. As Brianna knows, there are those challenges, and I've been prepared for those challenges. It's been
been difficult, but it's been worth it. We're doing something that I hear from social workers and LPC saying, I want to be doing this in the school district. I want to provide therapy, but they're doing a lot of the academic, which is so important, the IEPs, the 504s. They're doing a lot of those things where they want to do the other stuff, or they're so stretched thin, they're at 4 or 5 schools that they're unable to sit down for 40 minutes and have a clinical intervention. And also that red tape, for lack of better words, again, is the diagnose and treatment part. But you get a really good contract MOU. And again, I am happy to talk to anyone offline about those things. I would love for people not to reinvent the wheel or have to, or maybe, mitigate some of the barriers that we have had. But I will tell you, there has been challenges, but it's going well. It's going very well. Lots of growth. Yes. Yeah. I've learned along the way, and I would love to share those things with people because I wish I could have done certain things differently. It was difficult. And I think I mentioned the time period that we had when we got the grant and so excited in January 2022. I mean, we had 3 months, and first of all, hiring licensed clinicians that, to be in the schools, that was a huge challenge. And then the training, and then having all this into integrating, being a Driscoll employee, being basically putting a therapy, group session or therapist in a school has not been easy, but it's now becoming it. I have to say that in more than 50% of our schools, it is now, they have said to me, a principal yesterday said, I don't know what I would do without them now. It's becoming, they've relied on them now. They understand their role. So we're still working on it, but we're getting there.
And as Lisa said, we really do like to be as transparent as possible because it's most definitely not been easy breezy, but the whole way through we've learned some hard lessons, some costly, but we've also seen some things be really successful and work. So we're all about sharing that for anybody that has additional questions in regards to either of the projects.
Yeah, so group therapy, absolutely. We have group, we have many little group lunch groups. It's been great, from social skills to, we have a bunch of different ones, it's really interesting. Each school has designed their own little groups. And it's they love it too. The groups have been fun. So we absolutely have groups we've had more groups in the elementary, I have to say. In the high school right now, they're more seen individually, but at the elementary right now, but that may also be because our high school, one that's placed in their high school, she gets so many referrals every day. Her schedule is packed. Their goal is to see about 30 a week, but they have more consents and referrals than that. That's probably another reason there isn't so many groups in the high school, but in the elementary, we've implemented groups. How can we at the state level, as I work for Health and Human Services Commission, collaborate? I oversee all of Texas state funded SUD treatment for youth, residential, and outpatient providers. Please, again, reach out to us, email me. Would love to collaborate. That's an area that we truly are lacking, and we need to grow that. I think collaboration would be an amazing thing. Please reach out to me by my email. I'll also put in my chat my phone number as well. I would look forward to collaborating. Sorry, I'm sitting closer to the computer. I'm not usually, I'm sorry, I'm reading all the questions. Have we had any situations that require your team to activate mandated reporting action? Yes, absolutely. And we have. And I think with that, I wonder if the next would be we have, and yesterday, and is there fallout with that? Absolutely, just like with anything, right? It's difficult to have a therapeutic relationship once you've had to make a report, if that's what you mean by like child abuse report, if that's what you're asking. But, you know, mandated reporters, and that's what we need to do. And if it requires that intervention, then that's what we've had to do.